Hi, my name is Nakia Cosby. I'm a psychiatric nurse practitioner working in an outpatient mental health setting. Today I want to walk you through how I would manage a clinical crisis involving my established patients. My first patient is a 45-year-old male with a history of major depressive disorder and a previous pornograph addiction. He's presenting today in emotional distress and a very high risk of suicide. Upon entering the room, I immediately observed the patient's affect. He's visibly distressed, tearful, and overwhelmed. I perform a thorough mental status exam, noting psychomotor retardation, low mood, hopelessness, and poor eye contact. He reports discovering his wife's infidelity and abandonment, which triggered a profound emotional collapse. His symptoms include social withdrawal, occupational impairment, and increased alcohol use. I immediately completed a comprehensive suicide risk assessment. The patient reports having active suicidal ideation with a specific plan to shoot himself. He does identify a protective factor, his children, but acknowledges that hope is dwindling. This constitutes as a psychiatric emergency due to the presence of a plan and intent, along with substance use, isolation, and loss of psychosocial support. Immediate safety measures. I informed the patient empathetically but clearly that due to the seriousness of his suicidal ideation and active plan, he won't be able to go home today. I recommended voluntary inpatient hospitalization for stabilization. He did decline, so I had to initiate an involuntary commitment under Ohio law, considering the imminent risk to his life. I needed to ensure all of the lethal means are removed. So I asked about the accessibility of firearms and strongly encouraged him to allow a family member or friend to remove them from his home temporarily. If not possible, law enforcement assistance may be necessary. His alcohol use increases his suicide risk and complicates his depression. I would include a brief intervention of alcohol misuse, and once stabilized, consider referral for dual diagnosis treatment. I also asked if he has any trusted friends or family that he can speak to, and encourage involvement in support groups for divorced or grieving fathers to help rebuild his support system. Once stabilized, his treatment will involve medication reassessment, possibly increasing his Celexa that he's currently on, or possibly switching to a different SSR or SSNRI based on the response. I suggested CBT or interpersonal therapy focused on grief, loss, and rebuilding his self-esteem. I suggested alcohol cessation treatment post his inpatient hospitalizational stay. And I suggested legal visitation support referral for access to his children, and close outpatient follow-up every 1 to 2 weeks initially after his discharge. In crises like this, early intervention, empathy, and assertive risk management are very, very crucial. We need to listen carefully and validate the patient's emotions and act swiftly to preserve life. My focus is not just treating his depression, but preserving hope, safety, and restoring function. My second patient is a 19-year-old postpartum female experiencing what appears to be acute psychiatric crisis, possibly postpartum psychosis. It is very rare, but very severe and serious, and requires urgent intervention. During this visit, I noticed the patient was dressed provocatively in heavy makeup, both of which deviates significantly from her usual presentation. Her speech was pressured, loud, tangential, and contained loose associations. These are a hallmark sign of manic or psychotic episodes. She believes her baby is an alien and speaks about taking the baby to the desert for aliens to retrieve. This represents delusional thinking with potential danger to the infant. She denies any SI or HI, but the content of her delusions and disorganized thinking indicates she lacks insight and poses a risk to the children. Her husband confirms recent behavioral changes and expresses concern for the baby's safety. This corroborates that psychiatric decompensation is new and very concerning. Given the risk and due to her delusional beliefs, I immediately determined that the patient needs inpatient psychiatric hospitalization. This is not safe for outpatient to manage. I compassionately explained to both the patient and her husband that although she does not feel she is a danger, the nature of her symptoms and the risk to the baby require urgent treatment in a safe setting. She was unwilling to go, so I again had to initiate an involuntary commitment due to her impaired judgment and danger to the baby. I also had to contact CPS, which is Children's Services, to get them involved immediately to ensure the baby is cared for appropriately during the mother's treatment. I will work with the husband and social work services to arrange safe placement for the baby, preferably with the father or another trusted caregiver. A full diagnostic workup will be needed for the patient to rule out bipolar disorder, substance-induced psychosis, or postpartum psychosis. She'll need to be initiated on antipsychotic medications, such as olanzapine, or risperidone, and possibly a mood stabilizer like lithium or Depakote if bipolar disorder is suspected. Recommendation for ECT if the medication fails or symptoms worsen. Psychiatric education and family support will be very, very crucial during this time and after discharge. Post-discharge, I'd recommend a mother-baby inpatient unit if available, and ongoing psychotherapy and medication management. This case highlights the importance of prompt recognition and swift intervention in postpartum psychosis. Early treatment can protect the baby, restore maternal health, and preserve family structures. As a psychiatric nurse practitioner, our role is not just to diagnose and treat, but to act as a patient advocate when safety is at risk. I thank you very much for listening to my presentation, and have a good day.